So as I said, my name's Guy Bradburn. I am the ward manager on the renal transplant unit in Manchester. I've been given the wonderful last presentation slot where I'm probably repeating some information that you've already had and trying to keep your attention away from lunch at 11 o'clock in the morning. So I'll do my best to do both of those things. Okay. So very briefly, my career in transplant started in 2011. As a newly qualified Band 5 nurse, and I've worked in lots of different roles throughout transplant. I was a charge nurse on the ward, which is a junior sister. I then went with the transplant coordinator team for a little while, and then in January 2020, came to be the unit manager on the transplant unit. January 20 is fairly significant in terms of healthcare because it was also, I think, the beginning of the biggest part of the COVID-19 kind of pandemic, in terms of we stopped transplanting just a couple of months later in March. And so obviously quite a varied career throughout transplant and seeing the transplant unit in various different states over the last few years. So very briefly, again, Ward 45, and a couple of years ago it was rebranded as Manchester Centre for Transplantation, so MCT. We're currently located, as the picture shows there, on the 3rd floor. Technically, I think we're between the Eye Hospital and the St Mary's Hospital, which is the ladies' hospital, but we are still classed as Manchester Royal Infirmary. We're a 27-bedded mixed-sex unit. We have one ambulatory treatment room, which has kind of gone from strength to strength over the last few months. That was something that was introduced about 18 months ago for patients to come back to the unit and have various procedures, should they need them, or IV fluids and treatments to try and prevent admissions to hospital. We have 17 protected acute transplant beds on the unit and 10 transplant readmission beds. And I put 12 in brackets there because depending on the escalation state of the hospital, we can go from 10 to 12 readmission patients. But as I'm sure you're all more than aware, the pressures on hospitals mean that we're often in states of escalation, and more often than not are at 12 readmission patients. We are made up of 10 consultant surgeons, 9 transplant coordinators. We have our own dedicated transplant outpatient team. And last financial year, we did 230 adult kidney transplants, which was the second largest UK centre by volume. We used to be the largest, and that's obviously a title that we would like back one day, but we'll leave that there. So from our point of view, both with my transplant coordinator hat on and with my ward management hat on, the annual review for us is more about the very, very basic than obviously we've heard Dr. Battani and Mr. Dander talk about echoes and ECGs and various perfusion studies that you may or may not have to be listed for transplant and to remain on the list. But actually, from a nursing point of view, the most important thing for us is the absolute basics. So that's keeping up to date with name changes, whether that be from marriage, divorce, various other reasons, keeping your next of kin up to date, addresses as people move throughout the region. And I've put phone numbers there in capitals. Our biggest thing, obviously, one of our most important jobs is calling people in for transplantation. And there is absolutely nothing worse as a coordinator than being on call 2 a.m. sat at home on your own, on your laptop, and the phone number's dead at the other end. And, you know, we really struggle with that from time to time. So as part of that annual review, making sure all of your basic demographics are up to date is massive for us. I think it's a great time for both the patients and for their nephrologist or specialist nurse, whoever's completing the 12-month review, to have a look at potential issues that may crop up, call up. As I say, my career's in transplant has spanned 13 years to date, and I've heard some of the most bizarre stories that you'll ever hear of issues when we call people in for transplant. So obviously things to consider are pets, children, anyone that you may well have caring responsibilities for travel arrangements, work. Like I say, over the years we've had some crackers. We had a lady who had a diabetic cat, and no one else was able to administer this cat's insulin. And you know, just some of the stories that crop up at 3 a.m. that people haven't thought about before are really important. The other thing that I think is probably more led by our nephrology colleagues is the monthly bloods that we ask patients to send in that are on the waiting list, reviewing at their annual appointment if those bloods are happening. Obviously, we have patients from various backgrounds, all different modalities, pre-dialysis, PD, and hemo. We tend to struggle least to get our hemodialysis patients' bloods just by the fact that they're hooked up to a machine, often in centres, a few times a week. So it's often more easy to get their up-to-date transplant screening bloods. And the other patients we sometimes struggle more with. But they're really important in terms of speed of transplant when patients arrive to us. The one thing we want to happen is a very quick transplant. And if we have up-to-date bloods, we're able to often issue a virtual cross-match, which means we can go to theatre sooner. Obviously, when I was asked to present here, I knew it would be a mix of both professionals and patients. So it's a bit of a mixed presentation. The map up on the slide there shows the area which, as a transplant centre that Manchester covers. Okay, the red areas are primarily for kidneys, and then the yellow areas we cover also for pancreas transplant or beta cell replacement. And that I just want to give some kind of indication in terms of when we're calling patients in, the logistics sometimes are a huge part of what we do. And you know, we have some challenges of getting people in. We cover right out to Anglesey and part of Mid Wales. Also, not shaded in on there, we cover the Isle of Man for their pancreas transplant programme. So that's always interesting in terms of call people in for there. So it's, I guess what I'm trying to say is to be aware and to have plans, ideally to get yourself to Manchester, but if not, at least have a plan for how we're going to get you there. The call up itself will usually take place. Well, like I say, there's another slide actually that talks about it in a bit more detail, but these are the kind of questions we're going to be asking patients. Is that the first call they've had? Can they get into hospital? Sometimes we're calling them and keeping them at home while we get some information and just checking in to check they're fit and well. Last dialysis sessions, do you have diabetes? Have you eaten and drink? When was the last time you had things to eat and drink? And again, another slide primarily for our patient cohort. Some patients are very fortunate and haven't had surgery prior to the transplant. Some have had PD lines and vascular access put in place. But whilst you're on the ward, it's important, and I guess for our nephrology colleagues in the presentation, you know, to help to try and prepare patients for what they may come across in terms of infusions, oxygen, lines, drains, and things like that. I know that Jeanette mentioned about the transplant school. I was part of the setup for that when I was in the transplant coordinators, helped to set that up. And as Jeanette said, it was nice to have that face-to-face aspect of that. And it was nice for us as a team, having taken referrals from Preston and Salford and other referring centres in the Northwest, to be able to meet the patients face-to-face. For some of them, it was their first time at the Manchester Royal Infirmary, so it was nice that they could find out where we were, find the car parks, find the entrances, find all the things that you don't need to find at 2 a.m. when you're stressed, excited, and nervous, all about a phone call that you've just received. One thing that often comes up is around length of stay. Now these numbers are quoted on our averages, and we suspect that these numbers have reduced slightly since the COVID pandemic. We've introduced an enhanced recovery process for our kidney transplant recipients, and I think our average length of stay now for a live donor transplant is between 5 and 6 days. When a deceased donor transplant has lots more things that are out of our control. At the annual review, these are the kind of most important things that we feel we need to know as a team. The process currently is the patients have their annual review in their base centres, whether that be Salford, Preston. We have some referrals from Stoke and Wales, and that's usually then summarised in a letter that's sent on to our transplant coordinator and uploaded onto our new paperless system. Some of the things that I guess that are often missed out of letters are infectious status. We're aware that our patients, as a cohort, have a fairly high infection burden, and they're the hospital-acquired infections, sadly. Just by the fact that our patients are in hospital more than a lot of other cohorts of patients, in and out for dialysis, outpatient appointments, and various complications. So that's always helpful for us to know. Medication management, I know that Jeanette spoke at length about that. Obviously, it helps us to know if patients are using dose set boxes, if they're having any support with the medication, if they're independently dispensing and taking their meds. Mobility, again, we're aware that this changes and that patients are on the waiting list often for at least a couple of years, and their mobility at the beginning of that may be very different to how they present to us. Again, frailty. I know that there's been an awful lot of work done within the region by a couple of the consultants at Preston. We've done quite a lot of work on frailty in the renal patient population, but I don't think there is an agreed standardised approach to assessing frailty, certainly in the transplant waiting list. And again, that just gives us some idea of what level of support you're going to need on the ward and then going home. Any known disabilities, obviously patients are registered blind and partially sighted, or use hearing aids, that's helpful to know. Social circumstances, who people live with, and if there are any ongoing issues at home, what level of family support they have, and if they're going to require transport to and from the hospital. And then their activities of daily living. And again, some of these are less important. I think that it's important to note that we will assess all of our patients when they come to us. And obviously, post-operatively, things change fairly quickly. So do they have support or need support with cooking, cleaning, hygiene needs? We use occupational therapists on the ward and physiotherapists to try and help support. And then in terms of follow-up, where the follow-up is going to take place, obviously, for the large part, immediately post-operatively, they're going to come back to Manchester, usually for anywhere between 3 and 6 months, is what we expect. Ideally, it's at 3 months we would get people back to base, but that doesn't always happen. And also, and some of the centres, we now have a relationship that take their patients straight back immediately post-op. They have their follow-up due to the distance that needs to be travelled. I think that, as others have said, the brief for the presentation, I've tried my best to cover. I'm more than happy to take any questions. I can talk about transplantation and the nuances of calling people in and the ward care all afternoon if needed. So I'm more than happy to be guided by what people want to know, rather than me just preach at the end of 4 or 5 presentations. So that's everything from me. Thank you.